so that we will be here and playing. All right, so you also have like 3 opportunities to take these quizzes too. So it doesn't necessarily mean like, oh gosh, I have to take these quizzes 3 times and get a perfect score by the end of the week. That means that you can go back throughout the time that you guys have access to all of this. So, you know, say you take the pharmacology quizzes and then, you know, maybe like week 7 or week 8 or whatever, you want to go back and retake the quizzes, see how well you're doing at that point, and see how you're doing, you know, after you've taken much more of the course, and go from there. So you don't have to feel like, oh my gosh, I have to keep retaking these quizzes till I get 100% right. No, that's not how you guys learn. So don't worry about that. And then of course too, if you guys have questions anytime, you guys can email me. You can send me a message on Facebook. You can reach out to me on Moodle, anything like that. Please feel free. I will get back to you as soon as I possibly can. So don't worry. We also have our own Facebook group page if you're not currently on it. So we have VTNE Prep, yes, but then we also have the crash course page. So if there's something regarding the crash course, feel free to go to the crash course group page. If I'm not able to answer it right away, there's probably someone else that's able to answer your questions, or you guys can bounce ideas off of each other too. So it's much easier to go there and ask those questions versus going to the big Facebook page, because other people who might not be in the crash course can sometimes get confused on what you're asking, or sometimes people think that you're asking a question about vet tech prep and then they don't realize you're talking about the crash course, and then it gets really confusing. So it was just easier to separate the group, our group, from the actual VTNE prep. So trying to think, what else did you guys have? So you got onto Moodle. Did you guys see the pocketbook project concept at all on Moodle?
Did we see it, or how did we feel about it?
I guess both.
I saw it, and it looked like a lot of good info in one compact little guide. So is the idea for us to kind of like make our own like physical little notebook and then fill our notebook with all of those things to like reference and stuff?
Correct.
Okay.
Absolutely. And it is like your own thing to do. So there's no one way of doing it either. So what may work for you may not work for someone else. So that's why I kind of leave it as a blanket. Like, I don't give too much direction on it. It's more like, here are the things that should be included. And honestly, I could probably put so much more in there, like parasitology stuff and all of that in there. But once I continue to keep adding things to it, it's just this never ending project. So, but what's nice about it is it's like a cheat sheet book, I guess. So it's a quick reference for you guys to like be able to keep going back to and re-emphasize certain things that hopefully you'll be able to go, okay, I can recall this really quickly. What I would say is don't get too wrapped up into making it look really pretty, because then the book will never happen.
I've been guilty of.
You can always make a separate one later if you want to make a really pretty one. But I've had students along the way go, well, I just want to make it look pretty. So I like ordered all this stuff, and then weeks go by and I'm like, okay, like just like get it done.
Yeah.
You know? So, but if you want to make one for work later on or something to make it look pretty, like make the first one your, first draft or something.
What are your thoughts about like making it like typing it versus handwriting it? Like, would you recommend one over the other, or just how you learn, I guess?
I think it just depends on how you learn,
Okay.
because I've seen both. And yeah, like whatever is best for you. Because there are some people who type so much
Yeah.
better and faster
Yeah.
versus other people who write it down and it's better and faster, but whatever way works best for you.
Okay.
So
Do you have like a template that like kind of gives like what you think that we should put, or is it like subjective, like as per the person?
so I have the sheet of in there that what you should include, yes. And I broke it up into sort of like the subject ideas of how it should go, but I don't get too specific of like where you should put it, because I want you guys to organize it. Everyone's brain gets organized so differently, so I don't want to get it too crazy. So
I guess I only looked at the little short video you had on it. So there is like a template type thing.
yes.
Okay,
Yeah.
perfect. Thank you.
Mm-hmm. Yeah, and out of all of the books that I have received over the years for it, because I did it even when I taught in colleges, they are all so different. So that's why I don't get to like, here's the template versions of everything, because everyone's so different. So let's see. So yeah, I mean, the best thing that you guys can do though is to literally every single week that we meet together, or as you guys are going through, is to literally put things as you go through, because otherwise you just lose everything that you learn. So like I said, it doesn't have to be pretty. Just things that you can recall and put down on paper, is the best way. None of this is pretty. I swear, none of your studying is pretty. All right, wonderful. So how many of you really love pharmacology?
Love it.
Really?
No,
Wow.
I'm sorry. That was sarcasm.
Oh, okay. I was like, really? Wow. Okay.
I don't know.
I mean, I think I've met like a couple people out of a lot who actually do love it. And I was like, all right, well, I'm going to sit back on this one. But yeah, I mean, pharmacology is a whole like new language. So it's, unless you come from outer space, like it's not something that is like people, unless you had a really amazing teacher who just blew your mind away, like that you truly just love it. So yeah, it's a hard course to take. It's a hard thing to really grasp over time, and there's a lot of information that you guys typically take pharmacology at the beginning-ish of school, so, and you don't really emphasize it as much throughout the time that you're in school, right? So a lot of people struggle with it. So all right, so tell me some things that you guys have struggled with in pharmacology.
For me, it's been like the constant rate infusions, and just like dilutions can get me up from time to time when there's like percentages and stuff like that. And also when there's multiple steps to a problem. I was watching some of the videos that guy, I forget his name, but he was very helpful.
Okay.
In
Probably David Liss.
Yeah, he was
Okay.
helpful. But it was just like, and he was really good at breaking it down. But for me, it's like figuring out what it was helpful to figure out like what I needed, which was good. But then it was like how to get to each, like what steps to take and in what order, basically. And the multiple step ones I would say are the most complicated for me, for sure.
Got
I
it.
have trouble memorizing the different formulas that we have to use. I'm
Got
like
it.
terrified of that. And then also I'm having trouble with like the different pathways, like which medications affect which pathways, the
Okay.
receptors.
Yes. Yes. That can be difficult. Yeah. Like your anticholinergics, cholinergics, and then yeah, like your pain pathways and all of that jazz, like the actual physiologic aspects to it, versus that what is actually being used in practice and sending them home per se. Yeah.
I think that's a big thing for me is like, because I've been out of school for about a year and I've been in practice for a year and I haven't taken the VTNE. So I'm very used and accustomed to all the drugs and all the things that I'm doing in practice. And I've kind of let a lot of things go, you know, that I don't use on a daily basis. And because like I'm in a dermatology clinic. So it's like there's a lot I don't use on a day-to-day basis that I was learned and taught in school. So this is a really good rehash for me of all the things I need to like help rejog my memory and memorize to like tackle the VTNE by the end of the year.
Yeah. Yeah, you use a lot of drugs that some of us general practice or even some emergency people probably don't deal with, but at the same time, as a derm tech, probably don't use a huge amount of medications that,
Yeah, it's a very, very niche thing. So I kind of need to, be around people that are in GP and like have more experience with other things that I don't, have access to on a daily basis and keep my memory jogged with that stuff. So,
yeah, absolutely. No, absolutely. Yeah, I mean, and it's one of these things that you have to really exercise yourself a lot of times because it can be really difficult to get, or I'm sorry, it can be really easy to get into the habit of just like, sending home these medications and then not really, or kind of forgetting about, like, okay, why do we not use this medication in these animals, or why do we pick this medication over this other medication, So because there's that one time where that doctor may forget that we don't use that medication in that animal, and we can help them in remembering that, or that another drug might be better for that animal versus the medication that they were going to send home. So it's a really good idea to be familiar with these things, and it does take time though to keep these things in mind. And I will say that when I was in school, after taking pharmacology, even after, taking my VTNE, I still didn't feel as comfortable as I probably do now with some of the pharmacological drugs out there. And not that I think that the VTNE is meant to do that, but it does take time. So, great. What are some other things that you guys think that make you weary about pharmacology? I see pharmacology as a lot of times people say, I need help with pharmacology. I need help with pharmacology. What are some other things? I think you're on silent, Alicia.
Mute me. There we go. Hi.
Hi.
Yeah, for me, it's kind of definitely the mathematics. Just remembering it all. Dilutions and CRIs tend to be what gets me more than anything else. And then also kind of the antibiotic aspect of it too, kind of remembering what goes with what generation and how that affects, but also, trying to figure out what goes with the different grams and kind of the choices of those tend to get me a little bit there too.
Okay. Perfect. Antibiotics, yes. Like who's broad spectrum, who goes where, what treats what.
Hmm.
Crazy as it may seem, right?
Yeah. And it was kind of one of those things I remember when I was working through school, and it was talking about, they had all the different generations, and then trying to figure out all of that just got a little confusing and kind of hard to understand. So that's where I do struggle a bit too.
Yeah, most definitely. And the interesting part too is to bring that up generation wise, and that so many of these other medications, not just talking about antibiotics, but many of these drugs treat for other things as well, so trying to remember that, we have drugs that, initially are treating for one thing, but we also utilize them for other things too. So, we're having to try to remember, they do treat for this thing, but then they also can be utilized for this other thing too. So, and then we have to be cautious in this animal, or this type of animal. So it's just a lot to remember. So it sounds like a lot of math, memorizing of formulas as usual. And then, just of physiologic things too. And then, there's like a lot of where things belong and where they all belong to stem from. So, that makes a ton of sense. Anything that we're missing?
For me, it's emergency drugs on how critical care.
Yeah. You came to the right place. I'm from critical care initially, so I love emergency stuff.
Yeah, I just got out of school and I'm mostly the floor nurse at the moment, and I see a lot of critical care and emergency stuff that I'm not allowed to do yet.
Oh,
and
yeah.
It still confuses me, so I want to learn that.
That's great. There's little things that we can do to try to make each other remember things. And so the easiest way to do that stuff is making things to help us memorize those things and who hopefully your teachers made things to help you memorize those things of mnemonics, like things to make you remember certain things of how to memorize that stuff, but we will get there. So of how to memorize certain drugs, of what we do to memorize these things. Same thing with like conversions. Did you guys work on conversions?
Mhm.
Okay. So because we work with all different shapes and sizes of animals, we have to convert a lot of our drugs and stuff like that to smaller patients or larger patients, right? So we have to know like to bigger sizes and smaller sizes and stuff. So on the VTNE, they do quite a few conversions. And so, whether you're good at memorizing conversions, or we can make nice, easy ways of doing conversions, which I have for you guys too, so that you guys know how to do that. So that's part of our math idea too. So, but we'll work on that. And then we'll talk about like pain medication wise, anesthesia meds, stuff like that too. And then also like toxins and what those toxins do, and then how that affects everything, as well as like nutrition, because that kind of somehow works into pharmacology in some aspects. When we're talking about vitamins and stuff too, that's kind of pushing the barrier of pharmacology, but we do have some supplements in pharmacology. I try to put that into nutrition because we have a lot packed in into pharmacology, but we'll go through all of that. But we work on math stuff throughout this whole time, so don't feel like today is our only math day. So all right, so let's start with, how do I want this? Oh, I don't know. Let's start with emergency drugs because that one won't be fun. Let me just grab my sheet. So I'm just going to share my screen with you guys really fast. So I will warn you that my writing is terrible because I have to write straight up and down, but my writing's still terrible anyway. So when we talk about emergency drugs that you guys specifically need to know, our emergency drugs are 5 different drugs off the bat, right? And so how do we know those drugs? How do you guys know of them? Or have them memorized?
Is it the naval drugs?
Good. Yeah, naval, right? So you think of them as naval, right? So what is, before we start naming the drugs, what is so special about the naval drugs? What is the one big thing about the naval drugs that is so incredible that only these drugs we can do with these drugs that no other drugs we can do with?
Pretty much restart all the cardiovascular and respiratory systems up.
We have other drugs that can do that, but these drugs in particular, we can only use somehow. They can only be given this route. Well, I should say we can give them other routes, but
Intracardiac.
oh
Endotrache-
no. Yes. We can give them down the endotracheal tube, right? All the other drugs we cannot. So if we give them down the intratracheal tube, right? What is the dosing for it?
Isn't it like,
You double it.
yeah,
You double the what dose? Double the IV dose, right?
Mhm.
Good. I know. I made it sound like really harder than it was, but you're right. You double the IV dose. Perfect. So, I mean, I guess you could give other drugs down the endotracheal tube, but they wouldn't work. So, so what is our N drug?
norepinephrine?
That's
Naloxone.
naloxone. Good. Norepinephrine is the N drug, but it's not our one on this list. Naloxone. Good. So what does naloxone do?
Reverses opioids.
Good. It reverses. So it's our reversal.
Antagonist.
Good. Or antagonist. Very good. Of our opioids. Very good. So it is a pure antagonist, right? Meaning it reverses all of our opioids. Or I should say, it reverses, it's a pure reversal of the opioids. All right. So what are some of our opioids that we're talking about here?
Like Torb.
Morphine, hydro.
Morphine, hydro, Torb,
That's a partial. agonist.
partial. Good, good. So not necessarily. Torb is a little bit weird, but you're right on morphine, hydromorphone, fentanyl.
Butorphanol. Oh wait, no, that's Torb.
We can't count Torb or buprenorphine because those are both partial, right? But very good. How about our A in this sense?
Atropine.
Atropine. I'm like, Emily, I think you said, but I couldn't
Yeah, I
hear you.
wasn't sure.
Atropine, good. Atropine, very good. All right. So atropine, I'm going to get to in just a, well, we'll start talking about it actually. So what does atropine do?
Increases heart rate.
It increases our heart rate, right? Okay. All right. And is this fast acting? Like it starts, it works right pretty quickly, correct?
Pretty quick, yeah.
Okay. And what is another drug that's very similar to atropine?
The glycoprotease. is that what it
Good, glycopyrrolate, yeah.
Pyrrolate.
It has 2 R's in it. It just throws you off. And why would we choose atropine over glycopyrrolate in certain cases over others?
Atropine works right away, but glycopyrrolate takes a little bit longer.
Yes. So atropine, like in an emergency situation, right? We would want to use it for that situation because we needed to increase the heart rate right there, right now, right? But if we are going to do a long procedure, like in a surgery or something, and we want to make sure that our heart rate stays up during that procedure, we may choose glycopyrrolate instead because glycopyrrolate takes a little bit longer to work, right? But it's going to last us much longer, correct? So it's more of like a long distance runner, right? So we might not need it to work necessarily right away, but we want it to last that longer period of time, which atropine works right away, but it cuts out. It's a short distance runner. It cuts out quicker. So how about vasopressin is our next one. I just gave you the answer because I'm not thinking. Vasopressin. What does vasopressin do?
The bronchodilate.
So maybe not necessarily a bronchodilator per se. What do we want it to do in emergency situation if we are trying to jumpstart our body system? We have cardiovascular and
Is it
respiratory.
lower
collapse.
blood pressure?
Not lower.
Increase blood pressure?
Yes,
Mhm.
increase.
Oh.
Yeah,
Okay, yes.
yeah. Yeah, so it's going to constrict our blood vessels, right? So when we constrict our blood vessels, it's going to make our blood pressure increase, right? So meaning if we have relaxed vessels, then everything in our blood pressure relaxes, right? So we want to have that constriction there. Okay. So how about our E?
Epinephrine?
Epinephrine. All right. So what is epinephrine? This is where we get people sometimes. People like, we give it, but we don't know why we give it.
Don't we give it if the heart stopped?
Okay.
So it's kind of another one like atropine where it kind of jump starts the heart.
Okay. So we jumpstart the heart, right? So we want to jumpstart the heart. So what does it do other than jumpstarting the heart? So to jumpstart.
It's adrenaline, so adrenal glands. And
Okay. So it's adrenaline. So you're right. So what does adrenaline essentially do?
Well, doesn't it increase your heart rate, your muscle strength, blood
Yes.
pressure?
Fight or flight.
The muscle strength is what I was going for. So the contractility of your heart, right? So we're looking at increasing contractility of the heart. So say like our patient is officially, maybe not completely dead yet, right? We still may give epinephrine because we want that contractility of the heart to get better, right? Because we want epinephrine going, your adrenaline could be going, but you might not be completely dead yet, right? But your heart is going like crazy. So we give epinephrine and then we give atropine to increase the heart rate to keep it going, right? So you don't just give epinephrine and then not give atropine, because you can give epinephrine and then eventually the adrenaline will stop, right? Your adrenaline quits out on you after a while. But if you give atropine, the heart rate will continue to increase and keep going, right? Does that make sense?
Yeah.
Okay, cool. Yeah, people are like, I don't know why we give epinephrine. And I'm like, we just give it to give it. Also, epinephrine is used for many different things too. It's not just, we give epinephrine only when they code. Like, what other things can we give it for? In human medicine, we give it a lot, and people know this, but in animals, we don't really think of this because
Anaphylaxis?
yeah, anaphylaxis, right? Many times in animals, we just jump for our Benadryl and dexamethasone because that is typically the first course of treatment and we can catch it right away. But in humans, we see it on TV so much that they need epinephrine right away because That's just, we see those really bad ones that are so severe. Most people treat their anaphylaxis or allergic reactions at home, and it gets really severe where they have to go to the hospital for some sort of epinephrine at home. People don't necessarily treat all their animals at home for Benadryl or whatever. Not necessarily all the time. What else can we use epinephrine for in our patients? Maybe some of you have done it in your practice.
Certain local blocks.
Okay. Not as a lone course.
Yeah, that one with
Yeah.
that and bupivacaine commonly together.
Okay. Usually that's with another drug, but what do we use epinephrine for an emergency case that comes in?
Do you mean like if like the patient is they have like a slow heart rate or their heart rate has stopped?
Nope.
Okay.
This is something definitely walks into a practice.
You have a hint?
It has nothing to do with the heart.
Toxin?
Oh, it could be toxin. I wasn't even thinking that. So there's two things. I was thinking nosebleed.
Mm.
Actually, the toxin's more atropine, but so the toxin for atropine, why would there's one toxin for atropine versus epinephrine, especially with cats? What toxin with atropine do we use?
Lilies?
Not lilies.
Is that amphetamine?
No, that would actually be opposite. Organophosphate? What is atropine? What category does it belong to?
An anticholinergic.
An anticholinergic. So what do anticholinergics do?
So it's slow saliva and mucus production.
Yeah. So it sucks up the sludges, they say, right? So saliva, urination, defecation, all of that, right? So with any like organophosphate toxicities, all of that stuff, a lot of times with those guys is that they salivate like crazy. They have all this, they have bunch of stuff, but that's one of their symptoms. So we can give them atropine as one partial treatment for that. All right, so going back to epinephrine, if they have a nosebleed, it vasoconstricts. And so Same thing with lidocaine, it vasoconstricts. So if they come in and they have epistaxis, so nosebleed, is that you can get, a bunch of epinephrine and just inject into their nostril, of whatever nostril they're bleeding from, and put that in their nose and then ice pack it to just try to stop the bleeding until you can, figure out why they're bleeding and whatnot too, to just minimize that trauma.
That can be injected like if you're doing a dental or like doing a procedure, like where it won't stop there too. You can inject it.
Correct. Yeah. Absolutely. So these are the reasons why it's super important to know, like, all right, what about my drugs? Correct. Do I know what they do so that we can make things, run a little bit smoother and stuff, and not just think like, oh, I can cauterize or try to suture or do whatever. So trying to use some of your, drugs on top of it. So sometimes that's why we put a little bit of epinephrine in some of our drugs or whatever too, is to try to vasoconstrict certain things. Okay, so the last one, L.
Lidocaine.
Lidocaine. All right. And then why do we use lidocaine in our naval drugs?
Reduces arrhythmias.
Okay, so and how does it do that?
It blocks certain contractility, right? Because it's a local anesthetic.
Good. So essentially is that your heart is a muscle. And so just like any other muscles that we could be blocking, lidocaine is able to relax your heart too during those really stressful times for your heart, right? So if we give lidocaine as a bolus, we can give it time to reset and potentially get rid of that arrhythmia that it might be throwing during that time. So if that works, we could always put it on a CRI during that time and relieve it from that pain that's going through. And if it doesn't work, we can always go to stronger drugs during that time and do that. But if we can just use lidocaine, that's fabulous. Now we also use lidocaine for other things too, so local blocks and stuff, of course. But during naval drugs that we're using, we use it for a local anesthetic for our heart to help with the arrhythmias. So, all right. So those are our main drugs that we use for our emergency drugs. Now we do have other drugs that we use. So to kind of go over some of them, let's talk about some of those now. So if we have a patient that comes in who is having seizures, what are some of our drugs that we could potentially use?
Diazepam.
All right, so diazepam, right? So that's like our go-to drug right away, right? And so how do we administer diazepam?
IV usually, or interrectally.
IV, rectally. How else can we administer this?
Can you do it orally? I don't think it works as well.
Oral, you can, yeah. And we have one other way. Intranasal.
Hmm.
So intranasals actually, they can actually absorb it better than rectally. It's just harder because you're dealing with teeth than, especially with owners, right? If they're at home, than going towards the rectum. So, but it's good to know if they can get it intranasal. So, orally, we have to be aware of too, because if we're not thinking emergency, right? And we're thinking of other routes like for behavioral and stuff like that, we do have tablets and stuff too that are given. So we still have that other option. But if we're thinking emergency wise, we have those other three. Okay, so we have diazepam, and then say, because we have, you know, back orders and stuff like that, we do have the other option too is what?
Midazolam?
Midazolam, which one would we prefer to give?
Diazepam.
And why is that?
More rapid acting, and I think, and tends to be more effective in staying longer versus the midazolam.
Okay, so you're correct in that it is rapid acting. Yes, it does work faster. Diazepam only lasts for about 20 minutes. Midazolam lasts for about 40 minutes. So if we're thinking again of short distance runner, diazepam, long distance runner, midazolam. So it's kind of like playing of the better of two evils, right? Which one is fat soluble versus water soluble?
Diazepam's fat soluble.
Good. So if we had to give one a different route, we could give this one IM, right? So if worse came to worse, especially if we're talking anesthesia wise, we can give midazolam IM. In other cases, not necessarily emergency cases, but in other cases, we can give that one IM if we needed to. Which one binds to plastic? Or do they both bind to plastic?
Or both of them?
Both bind.
No, diazepam binds to plastic. So midazolam does not bind to plastic. So if you're doing like a CRI of diazepam, so like say we have a seizure patient who needs to be on one of these for a longer period of time to rest their brain for a long time, you're better off having them on midazolam to rest for, sometimes we keep them on diazepam or midazolam for like 24 hours and then see how they do as we slowly wean them off. It's better to keep them on midazolam so that we don't have to switch off you know, the diazepam every 6 hours, and it wastes a lot of that diazepam then, especially when we were on a shortage of diazepam. So it's better to do midazolam that way so you don't waste like 8 mLs of diazepam every 4 hours. So it's better to do that. Now they both are light sensitive, so you do have to keep them both covered. So that is the downfall in that realm of things. So it's if we needed to, if they're in an active seizure at that given point in time or a status seizure, we go ahead and do diazepam, and then if they need to be in a CRI, we go ahead and switch them over to midazolam. So very good. All right, so What are some of our other seizure medications that we have out there?
Phenobarbital, Keppra.
All right, so phenobarbital. So phenobarbital. And what is phenobarbital? Like what group does that belong to?
Barbiturates.
A barbiturate, very good. What do we know about barbiturates? Or what do you know about a barbiturate?
It's used in euthanasias.
Okay, very good. Now, is phenobarbital a long-acting barbiturate or short-acting barbiturate?
Long-acting.
Long-acting, very good. Now, pentobarbital, which we use in our euthanasias, is short-acting. I just say because we don't use it very long. That's how I remember it, which is kind of morbid. So this is long-acting, right? So, so phenobarbital, what routes do we give phenobarbital?
Orally, IV.
Don't overthink it. That's it, right?
I think so.
Yeah. And then what's interesting about phenobarbital? How is it, what's the concentration like? Is it different than other drugs?
Yeah, they usually have it in grains.
Yes. Why? Because they have to throw us all off, right? So what does 1 grain, this is what grain looks like, right? Versus what's that?
Grams.
Gram, right? So what is grain? What does that equal in milligrams? Roughly.
No, like 62.5.
65.
That
60, sorry.
was it like 62.5 or something?
You're close. It's like 64.8 or 64.
64.8.
Yeah, something like that. I say as long as you get somewhere close to 65, we're good. So phenobarbital is probably one of our oldest maintenance seizure drugs that we have out there. It's usually, used probably one of the most used out there, right? To maintain seizures. What do we have to be cautious with when we have a patient who's on phenobarbital?
Liver toxicity.
Mm-hmm. So they have to have their liver checked every so often, right? I mean, anything that an animal puts in their body, same thing with people, right? There's some sort of side effect most of the time, right? But our liver, as I tell people, is our garbage disposal of our body. So many of our drugs are metabolized by the liver. And so phenobarbital is no different. And so especially when they are on a chronic medication, they have to have their blood work done every so often to make sure that their liver is okay. And so we have to make sure that we are not doing any type of damage. So they do that how often usually?
It's usually yearly, isn't it?
Okay, I would say somewhere between every 6 months to a year, just depending on how conservative or, you know, like your doctor is and whatnot. Sometimes there's other blood work. I don't want to give out away all the answers here. If your doctor is already checking blood work for other things, they just might do liver values at that time. So it just kind of depends. What other blood work do you check as well?
Phenobarbital levels.
Good, good. So phenobarbital levels. So why do we check phenobarbital levels?
To make sure they're at a good like therapeutic dose.
Good, good. So there's a therapeutic dose. Now, the therapeutic dose being that they have to be what? Like, I get, right? They have to be at least, you know, hitting a certain number, right? What if they're over that number? Is that okay?
No.
That sounded sure.
I think you'd want them to be, you know, within the normal. You don't want them to get more phenobarb than they need. So,
Okay.
you know, I think if you can lessen the amount of phenobarb they're getting, it would be better for them.
Okay. Why do you think that? I'm
Just 'cause
being your client now.
hard on their liver, and it,
Yeah.
you know, yeah.
Yeah, absolutely, right? So yeah, we want to keep them within the therapeutic range because they definitely don't need it. Plus, we're drugging them too much, right? So you know, we're being too harsh on their body. And eventually your body gets too used to that range, and we will eventually need to go up on that dose, which we don't want either. So you want to try to stay within that range. So very good. All right. So what's another drug we mentioned? So somebody mentioned the brand name of it.
Oh,
Levetiracetam.
Yeah.
Oh, we use the big name now. All right. Now I got to spell it. Oh. All right, which is also known as Keppra. Okay, so this is a fun drug, right? So what do we like about Keppra? And then what do we not like about Keppra?
Not as harsh on the liver and kidney, but it is short acting.
Good, good. Very true. So it is a lot safer, you're right, on the body, like not as harsh on our liver. And you mentioned it being short acting. So how often do we have to typically give it?
8 hours.
Every 8 hours, right? So if you have at least, so have to give, so this is a good medication if you have someone who is going to be around, you know, every 8 hours for their pet. So if you have someone who is traveling or, you know, works long hours, might not be the best drug for their pet.
Now, is that the same with the extended release, or is that just the regular Keppra?
This would be regular Keppra. Yeah. Extended release is much newer to the market. And extended release doesn't, I want to say, it doesn't fit the glove for each patient, depending on how severe their seizures are, because I think there still are going to be some cases where not necessarily every 8 hours, I wouldn't say every 8 hours, but they're still having to do other medications too. So it's a little sketchy. So, but it's still better than the old Keppra. So, all right. So, what is our next drug that we also have? Oh, and we also give this as well, PO and IV. How many of you guys do potassium bromide?
Very rarely.
Really? I came from specialty, so when we had neurology, we would have some patients on all three. So yeah, some were hot mess. So what's important with potassium bromide? Something to do with their eating.
Increase appetite.
They have to eat a low sodium diet. And then you have to give the potassium bromide with food. Anyone hear of zonisamide?
Yeah, we use onisamide a lot.
Yeah. What do you use zonisamide for? What type of seizures?
Clusters.
Okay. Do you use them for generalized seizures or focal seizures or facial focal or?
We use them for generalized seizures.
Okay. It's a pretty safe drug. So I think that's why people are starting to use it more often than using some of the other ones right off the bat, which is kind of nice. But it's a really good one to be aware of too.
And I think the monitoring on it is not as extensive as a phenobarb.
Yep, absolutely. Yeah. And it has a good wide range too on it. So that's the nice part. I think my one dog had a weird, like one of the only dogs to ever have a weird side effect of it, because every other animal always has been very safe with it other than my own pet. So, but it is a very safe drug. So, but yes, that is another drug that is out there. And then lastly, this is in our anticonvulsants too, even though we do not use it as an anticonvulsant. Is gabapentin. It was initially made as an anticonvulsant, and it's a very sucky anticonvulsant. In human medicine, it is used as a baby anticonvulsant, and it's not a great anticonvulsant. But we found better uses for it. So what do we actually use it for?
Pain control.
Okay, that's
Neurologic.
one. Okay, so
Anti-anxiety, sedation.
okay, so we use it for anxiety, and we use it for what type of pain control specifically?
Neurologic.
Nerve pain control. Good. Perfect.
My dog was on it for his spondylosis.
Yeah, that's actually a really great reason to be on it for spondylosis. Yeah. Was your dog only on gabapentin for spondylosis, or a bunch of them?
Yeah, he died last year, but I had him
Oh.
on gabapentin for primarily the spondylosis, and then we started using meloxicam tablets for his arthritis.
Yeah. Yeah, that's rough. Poor thing. Okay, so now we've covered seizures. That's a lot for seizures, right? Oh, and I guess that we should forget. So say all else fails. So our animal is still having seizures through, right? What else could we give our patient?
The clorazepam. Clorazepam.
Propofol.
Propofol. There we go. That's what I was going for. Yes, propofol. We can give propofol. So yeah, we can knock them out with propofol. And then sometimes people will even just, if they don't want to keep them on a propofol CRI, will completely knock them out like under isoflurane if they don't have even enough like propofol, or they just want them under isoflurane. They can do that too. But we've done like, just like we've done diazepam or midazolam CRIs, we've done propofol CRIs too. So, but sometimes their poor brain needs to rest. So, and just like restart completely. Okay. So if our patient comes in and they are, well, let's go over pain meds. Pain management is my friend. So they come in and they are in pain. We don't have to have a set like generalized idea of the pain that they're in per se, but let's go over their pain. So we have a couple different types of pain management we can do, right? So what are our different categories of pain management we can treat with our animals.
You see opioids.
Okay. And then what?
You got NSAIDs.
Okay. What else?
Can use glucocorticoids.
Okay, perfect. So steroids. Remember, it doesn't necessarily have to be oral or IV. So think outside the box.
Adequan? I don't know what that counts as.
What'd you say?
Adequan?
Oh, very good. Okay. I wasn't even thinking that. How about local block? What if it was just like, yeah, like what if it was just a nail trim or like a toenail, right? Like we get the craziest things that come in on the ER, right? Okay. So if we break this down, so our local blocks, we have our lidocaine, like you said. Oh goodness, there we go with my crazy writing. Lidocaine, bupivacaine, right? And our local blocks, which one burns?
Lidocaine.
Okay.
Yeah. So how do we make it not burn?
Sodium bicarb.
Yeah. So how do we figure that out? How do we add the sodium bicarb to it?
Is it half and half?
No. That'd be a lot of sodium bicarb. You're gonna change your pH of your blood if you do that. So you do, essentially you're gonna do 9 parts lidocaine, 1 part sodium bicarb. Okay. So it's just a little tiny bit of sodium bicarb. Hopefully you guys can kind of make that out. Now, also what you can do in your local blocks too, has anybody done any dexmedetomidine or buprenorphine in their lidocaine or bupivacaine? And it's like little microdoses. Or heard of it?
Like we've done a little bit for sedative.
Yeah, we use it to a lot in derm actually. Like my clinic, we use Dextome, and then once they're down, then like we use lidocaine. And I honestly just use like the lidocaine. Then I use I fill the hub honestly with the bicarb, and just put a little bit of and fill the hub, and then we use that as the local block, and then we do a biopsy. And
okay, perfect.
And then we reverse with the antecedent.
Yeah.
Okay. So what I'm talking about in here in the lidocaine or in the bupivacaine is adding in either dexmedetomidine or buprenorphine in with your lidocaine or bupivacaine on top of it. So there's a couple of papers too saying to add that into conjunction. And what it does is you know how lidocaine only works for maybe a couple hours and then bupivacaine works for like 4 to 6 hours? It actually makes your lidocaine and bupivacaine last for up to, at times, 24 hours in length of time. So it's actually really nice, especially like not to say on emergency reasons per se, but for like, say you have some of these dentals that have really bad extractions, or like you're doing a testicular block or anything to that nature where you want some of the pain management to last a little bit longer, or even if it's like a really bad laceration repair and they are just going home with, you know, an NSAID. It's nice because you don't have to necessarily send home opioids then with the patient. You can send home an NSAID, but your block is lasting an extra long period of time. So you're having really good pain control this way. And you don't have to feel like, you know what, I have to send home opioids on top of my NSAIDs because I don't feel like I have enough pain control. So it's nice to, again, play around with some of your medication to, you know, make sure that they work really nicely with each other.
Can you explain, like, what about the Dextome and what about the Bupe makes it last longer?
Yeah, they just augment the medications. So I have the papers on our VTNE Crash Course page. I can try to find them again because I posted them a while ago for you guys to read. But it's just like how like when, say you give oxytocin, right, to a patient, instead of just giving oxytocin, we give oxytocin and calcium gluconate to make the contractions work better. It's just in that same nature that they actually the drugs augment each other to work better and more effective. So that's essentially what it's doing. So it's just giving better pain control. So, but I'll search for those papers for you guys and try to repost it so that you can see them to read them better. And I might have them in the anesthesia section for this week coming up. And if not, again, I can just make sure that they're posted again.
Thank you.
Yeah. So a lot of the dental specialists I know that I'm working with have been utilizing the dexamethasone in their dental box. And then I know a lot of the general practice doctors in my area have been doing the buprenorphine in with their testicular blocks, and they like it. So versus just doing like the lidocaine or the bupivacaine. So, okay. So opioids. So we talked about some of them already, maybe. Our first one is, let's talk about the first baby opioid that we have. What one would that be?
Or
Tor, right? So butorphanol. All right. So how long does butorphanol last for our patients? Like, how long does it give pain control to them?
8 hours.
No, this might be a little shocking to you. If we give it IV to a patient, how long do you think it's going to give pain control for?
Isn't it like 15 minutes?
Ooh, maybe not that quickly, but close.
An hour?
You're much closer, yeah. So about 40 minutes. 40 minutes. So by the time you guys pre-med, get your catheter in, get them all scrubbed up, get them into surgery, ready to go, the pain meds have worn off. Now set it like the sedation factor is still there, you know, but pain control gone. So maybe not the best for certain types of procedures, right? So why do we use it?
For quick procedures?
Good. Yeah, like a quick procedure. Or we might not be using it for pain relief, right? Maybe we're using it for a different reason. Like, what else do we use butorphanol for?
sedation.
Sedation, right? Like, it's actually a pretty decent sedative for like a pre-med. So, like many times I would much rather give my NSAID to my patient way ahead of time and let my NSAID work. You know, just because it's an opioid doesn't mean that it's better than an NSAID. So if I could give my NSAID to my patient like a couple hours ahead of time, I would rather do that. Now here's the question of the day. If I gave carprofen to my patient sub-Q versus PO, which is going to get absorbed faster?
Sub-Q.
Are you sure about that?
Well, I guess if you are giving it PO, because I mean, it has to go through the liver and everything in terms of it, but it is dealing with that.
It's a trick question.
It is.
They both get absorbed in the same amount of time.
Interesting.
So they both take about 2 hours. So this is one of the things too, like doctors think the same thing, that if you give it sub-Q, if you give it IV, if I say IV because in Great Britain, they do give it IV, or I should say in Europe, not just Britain, but in Europe, they give it IV, and it takes the same amount of time. So it's better that we give our NSAIDs as almost like a pre-med for it to work by the time we're done with surgery, right? So that they have pain medication ready to go and working for them, right? So, or if you give the medication to them even the night before, so, you know, they already have pain control on board right away. So, kind of thinking ahead of the game, like, all right, maybe if we think proactively, because if we start treating pain, you know, then we're going to heal faster, right? If we're already ahead of the game of treating pain, they're going to heal right away. So, okay, so back to opioids. Butorphanol. Then what's after butorphanol when it comes to pain relief? We can pick any of them. I'm okay with it. We don't have to go in.
Ketamine.
Thinking opioids.
Yeah, because they're an alpha-2 antagonist.
Buprenorphine.
Buprenorphine, okay. All right. So buprenorphine is a good drug to use for maybe some of our spays and stuff like that too. If you guys don't want to have to use hydromorphone or anything like that, because hydromorphone is a Schedule II drug. And so sometimes that requires some more DEA like paperwork and stuff like that too. Plus buprenorphine has a longer duration of time that we're going to be able to have pain management for, right? So buprenorphine lasts for about 4 to 6 hours worth of time. Yeah. And it provides moderate amount of pain relief, so it's good. And we don't have like any amount of like weird side effects, even like sometimes hydro can have some weird side effects, right? What are some weird side effects that some animals get from hydromorphone? I'll put hydro on here.
They vomit or have GI upset, like diarrhea or something.
Yeah. Yeah, so hydromorphone essentially makes their GI system move right away, right? So I always say, like, take them out to the bathroom right away after they get hydro, right? Because otherwise they're going to go to the bathroom on your surgery table. So it's always a good idea. Now, why do people say that they vomit from hydromorphone? Does anyone use morphine in the practice right now? No? Oh goodness, good. I'm like, good. Phew. You guys would be just appalled with what morphine does. If you guys are all like, oh my gosh, hydro makes them vomit. Why do you guys see vomiting with hydro or with morphine?
Doesn't it affect the vomiting center of the brain?
Yes. But what is the initial cause there's one initial thing that it produces at first. Hydro produces less of it than morphine, but it still produces some. What does morphine produce? Anyone ever have morphine?
Does it make you dizzy?
It can, yeah, it can. But it also, it makes you itchy. Why? And it makes you want to vomit. Why? What would make you itchy?
Histamine release.
Yes. So hydro has a less of a histamine release, but there still is histamine release. So with that, that's where you get it, where you're going to still have that a little bit of vomiting issue and everything too. Now, how can we counteract that? We did talk about it a little bit, right?
Doing Serenia?
The Serenia, pre-med with Serenia. We give out Serenia like candy in emergency med. And so what does Serenia do?
An anti-nausea.
Good. What specifically does it do? It's an anti-nausea, but there's some other anti-nauseas. So what is so special about Serenia? It blocks something.
It blocks some receptor. I don't remember which one.
You're like, it means nothing to me because I don't understand it. Yeah. Substance P in the brain. That's what it's called. Substance P. So it essentially works specifically on the brain. So just like you were saying, the vomiting receptor in the brain, that's the vomiting receptor in the brain. So Serenia is already working on that vomiting receptor in the brain saying, nope, hydro, you can't have that vomiting receptor because my Serenia is controlling that. So that's kind of the cool part. Initially they thought, because, you know, I'm old and I was around when Serenia first came out, was that Serenia actually had pain control to it. And they have now come to find out that Serenia doesn't necessarily have that pain control. It's just that Serenia makes it so that animals feel much better after surgery, and because they are not nauseous and you know, like they used to be due to all these medications. And I think that we just never, because our animals don't speak to us, that they just clearly do so much better because of how nauseous they really were. So I think we just didn't realize how horrible they felt. So, okay. So, and like I said before, I mean, like we just waited till they threw up, 20 years ago, and then we went and did surgery, and it was like, why did we do that? Like, I wouldn't want to just wait until I threw up and then went and had surgery and thought that that was clearly normal. Like, that's not normal. That's not normal. I would never want to have surgery. I would never want, I mean, I don't want to have surgery, but like, I would just not think that that's normal. Fentanyl. So morphine is like the mother of opioids, right? So hydro is how much in strength times the morphine. Like how much more potent than morphine?
Like 100?
Ooh. No, not hydro.
Oh, I'm sorry. I thought you were saying fentanyl.
Oh, fentanyl, you're right. Yeah, fentanyl 100. I was like, man, hydro. People would be busting down the door for hydro. Okay, so what about hydro?
Four times.
4 times. Very good. So I mean, morphine's pretty strong of a drug. If you've ever had it. So like I've had it once for a surgery that I've had. I did not like being on morphine. I was very, very itchy and whatever. So I can imagine hydromorphone being 4 times as strong is definitely enough. I've had fentanyl before too, and that was after surgery. And I wasn't on it for very long. But I cannot imagine that being 100 times as potent, right? Now they say like thinking about being in the street as well, fentanyl can be up to 250 times as potent. And they also are saying too, just FYI for additional terms, they're also lacing fentanyl in the streets with I can't spell. Can't spell. Xylazine and dexmedetomidine. So these 2 drugs are veterinary specific drugs. So that means that people are breaking into our hospitals to get these drugs, right? So what are these 2 drugs? There's a method to my madness here of why I talk about these. What category do these drugs come from? Okay, so not this specific, they're not, you didn't give me the specific category, but they do sedate our animals, correct? But they are called what? Anyone?
Alpha 2.
Yeah, alpha 2 agonists, right? So they are called alpha 2. Ooh, why did I do that? Alpha 2 agonists. All right. So do these guys have any pain relief in them?
Yes.
Yes. Good. Now, did medetomidine have pain relief in it? This is like before your time. So there was medetomidine. There's medetomidine and dexmedetomidine. Do you guys know that?
Don't they use it in large animal medetomidine?
Probably, yeah. They also use it in small animal.
More commonly.
More commonly what?
More commonly in large animal than small.
Nope.
No.
Medetomidine is just colder.
Mm.
So they use xylazine most. So dexmedetomidine is newer. Medetomidine is just was older, and it's essentially cardiovascularly was just not as safe. So now you're seeing a lot more dexmedetomidine out there now than medetomidine, but of course we should always know our history of drugs. So you're not going to necessarily see medetomidine out there as much. You probably, it depends on the doctor of what you're going to see more in large animal, of whether you see dexmedetomidine versus xylazine. I personally see dexmedetomidine in small animal use more than xylazine. And I mean, in large animal, I've seen both used too. So like I said, it truly just depends. So, all right. So we have our alpha-2 agonists. If we have alpha-2 antagonists, so thinking of agonist being like our teenage, a teenager who wants to sleep in on the weekends, that's our agonist, right? So those guys. Antagonists, they're like the 5-year-old kid who wants to antagonize their teenage brother or sister, right? So they want to wake them up. Who are those antagonists?
Yohimbine.
Yeah, yohimbine.
Antecedent.
Okay, so antecedent, and then what's the generic name? Nobody ever wants to remember that one's name.
Antipamazole.
Antipamazole. Just remember, it's Pam. All right. So how do we pair these guys up? Who belongs to who?
Pam goes to Dex.
Pam goes to Dex, yeah. So the beginning of the alphabet ones, right, go together, and the end of the alphabet ones go together. So xylazine and yohimbine go together because they're at the end of the alphabet. And anipamazole and dexmedetomidine, they go together because they're at the beginning of the alphabet. Awesome. So now if we talk about our NSAIDs, all right? So we have 2 different types of NSAIDs, right? What are the 2 different types of NSAIDs? How are they broken down?
Does that have to do with prostaglandins and sodium channels?
Oh gosh, you're getting too crazy on me here. They're called COX-1s and COX-2s. COX-1, COX-2. The main ones that we deal with nowadays are going to be what?
COX-2.
COX-2, right? And why is that? What are our COX-1s? In a nutshell.
they deal with a lot of GI protectant and making sure that that's working okay.
Okay, so our COX-1 drugs, think of back in the day before we had COX-2s, right? COX-2s are like anti-inflammatory ones, right? These are the anti-inflammatory. COX-1 ones are coagulopathy ones, anti-coagulopathy. So think of like your great grandma who wanted to take her bare aspirin every day so she could prevent a heart attack, right? Those are your COX-1s. Yeah. So these are like your aspirin, or your ketoprofen is what we use in veterinary medicine, essentially, right? Or essentially aspirin. That's COX-1. COX-2 is what else is on our list? What are our anti-inflammatory drugs that we use in practice?
Carprofen,
Carprofen, good.
Galliprant.
Galliprant actually is a non-COX drug, so we can't count that one.
Oh.
That, of
Okay.
course, you say the one that I have to, yeah. But that one's actually considered a non-COX drug, but that one's actually a really good drug because it's really safe. So carprofen, oh, wait, what'd you say?
Meloxicam.
Oh, meloxicam, good. Meloxicam. Do you guys use daracoxib? Anyone?
No.
Nobody uses that anymore. So funny. Daracoxib. It's Daramax? No? Okay. Let's see. Robenacoxib. Right? Onsior? For your cats? Anyone use that?
Yes.
Yeah.
Okay. And then of course I forgot my non-COX. Galliprant. That's an I. Okay. What was Galliprant made initially for?
Arthritis.
What kind? There's only one arthritis, but I'm being really annoying.
Osteoarthritis.
Osteoarthritis. I'm like, I just want to be really annoying. Perfect. But what do we use it for? What do you guys use it for? Do you guys use it for other pain relief? Other than arthritis? Or do you guys strictly use it for arthritis cases?
I feel like it's strictly for arthritis.
Oh, okay. I mean, some people send it home for post-op surgery cases too. So I think, especially if they do like a, if they're going to go ahead and do a like TPLO or something to that effect. So I think that's interesting. All right, steroids. What's our steroids we use?
Prednisone.
Okay.
Prednisolone.
And prednisolone. What's the difference?
Different point within the breakdown with the enzyme aspect.
Good. So
One is species specific, right? One can be used in cats, and then the other one can be used in both.
correct. So which one do we use in cats?
Prednisolone.
Prednisolone, good. So prednisone breaks down to prednisolone, right? Cats can't break down prednisone, but they essentially have to take prednisolone. So we can give dogs prednisolone. Cats can't have prednisone. So say your practice only carries prednisolone to give to cats and dogs, that's totally fine. But we just can't carry only prednisone and give that to cats. That just won't work. So very good. What other steroids?
Is Percortin a steroid?
Medrol.
Good, good. Percortin, yes, a little bit different. Because we're going to be doing as an individual testing type of thing. Good. Like if you're doing a cortisol test. Sorry, what else did you say? Medrol? Yes. Medrol, yes. And then what about another injectable?
Dexium.
Oh, wait, what did you just say, Bree?
Dexium.
Yes. And then, oh gosh. Dexamethasone. And then you also have SP2. So just depending too on if you're doing injectable versus oral, that type of thing. Very good. Very, very good. So Adequan, what do we use Adequan for?
Osteoarthritis.
Yeah, joint pain.
Joint pain, very good. Osteoarthritis, yes. Do you guys use it in derm at all?
Not me specifically, but we do have a couple patients. Like I have a German Shepherd, Tamia, that comes in, and like I give her injections, her Adequan injections when she comes in, along with like her Cytopoint, and we do ACIT and stuff like that. So like immunotherapies and stuff like that.
Got it. Got it. So in conjunction with other things. Awesome. Yeah. Awesome. Perfect. Great, guys. So we're off to a good start, honestly, with some of pharmacology's stuff. There's a ton of stuff. So we have still a lot to go. A lot of it will kind of continue to filter into anesthesia and even in with surgeries. So keep up the great work. We will be doing a ton more in the next couple weeks. So continue working on all of the content within this week. And then if you have questions and stuff, we're going to be working on that within this next week. Next week, we're going to be working on some math and then also working too with doing farm with that. So I'll be asking you guys questions and kind of reinforcing the stuff that we worked on today. Again, reach out to me if you guys have questions. But yeah, keep keep doing everything that you guys are currently doing. If you have questions, reach out on the Facebook page too, if you run into anything. But yeah, great job.
Hey, Beth.
Truly.
Thank
Yeah.
you.
Yeah, thank you
Thanks.
very much.
Thank
Have a
you.
good rest of your
Hi,
weekend.
thank you.
Thank you.
Sure. Take care, guys. Have a good rest of your weekend.
Thank you. You
You
too.
too.
Sure. All right. Take care. Bye-bye.